All right, now we're moving into trauma, and this is one of the most important sections in the entire course. Trauma is a leading cause of death, especially in younger populations, and these are the patients where what you do and how quickly you do it matters. Unlike many medical patients, trauma patients often have a clear mechanism of injury, and your job is to use that information to anticipate what injuries might be present, even the ones you can't see yet. But remember, just because you can't see it doesn't mean it's not life-threatening. This chapter is going to lay the foundation for how you approach trauma patients. We're going to talk about things like mechanism of injury, how energy is transferred to the body, and how that translates into different injury patterns. You'll also start to build confidence that the mindset of thinking ahead, looking at a scene and already forming a picture of what could be going on internally. And just like always, our priorities don't change. Scene safety, primary assessment, and identifying life threats early. Before we jump into the trauma, let's look at the National EMS Education Standard competencies for this section. At its core, trauma is about applying your fundamental knowledge and skills to provide emergency care and safe transport for acutely injured patients. Everything you're going to learn in this chapter builds towards that goal. Taking what you know, applying it in real time, and making decisions based on your assessment findings. So this isn't just theory. This is where it all starts to come together in a very practical, real-world way. Taking that a step further, this chapter is going to focus on the trauma overview, so the big picture of how we approach injured patients. You'll be learning the pathophysiology, assessment, and management of trauma patients. We'll also introduce things like trauma scoring, which helps determine how severe a patient's injuries may be. And we'll talk about transport decisions, because where you take the patient and how quickly you get them there can make a huge difference in their outcome. That includes choosing the right destination and even the right mode of transport, whether that's ground or air. Finally, this section focuses on multi-system trauma. These are the patients who have injuries affecting more than one body system, and these are often your most critical patients. You'll learn how to recognize and manage multi-system trauma, which requires you to think quickly, prioritize effectively, and stay organized under pressure. We'll also dive into the pathophysiology and assessment of these patients, along with how to manage them in the field. And we'll touch on blast injuries as well, because those bring a unique set of challenges and injury patterns. As we get into trauma, it's important to understand just how significant this topic is. For people under age 44, traumatic injuries are the leading cause of death in the U.S., and that's huge, and it highlights why your role as an EMT is so critical in these situations. Traumatic injuries happen when physical forces are applied to the body, things like car crashes, falls, or penetrating injuries. That's different from medical emergencies, which are caused by internal conditions or illnesses, not an outside force. So right from the start, you want to be thinking, is this trauma or is this medical? One of the most important concepts in trauma is your index of suspicion. This is your awareness and your concern for serious injuries that you can't immediately see. Just because a patient looks okay on the outside doesn't mean everything is okay on the inside. You always want to be thinking ahead, based on the mechanism of injury, what could be going on internally. That mindset is what helps you catch life-threatening injuries and treat your patient appropriately. When we talk about trauma, we have to talk about energy, because that's really what causes injuries. Traumatic injury happens when the body is exposed to energy levels beyond what it can tolerate. That energy gets transferred into the body, and that's what causes damage to tissues and organs. This is where your mechanism of injury, or MOI, comes into play. The MOI is simply the way the injury happened, and it describes the forces acting on the body. And understanding that mechanism helps you predict what injuries might be present, even if you can't see them right away. To understand trauma, you also need a basic understanding of energy and how it behaves. There's three main types that we talk about. Potential energy, which is stored energy, like something elevated that has the potential to fall. Kinetic energy, which is energy in motion, like a moving vehicle. And the energy of work, which is the energy transferred when a force is applied to the body. And here's a key concept. Energy can't be created or destroyed. It can only be converted or transferred. So in trauma, that energy has to go somewhere. And unfortunately, it often gets transferred into the body, causing injuries. Now let's break down the idea of work in relation to trauma. Work is simply force acting over a distance. So when a force is applied to the body, whether it's bending, pulling, or compressing tissues, that energy is doing work on the body. And when that force exceeds what the tissues can tolerate, that's when injury occurs. So again, it all comes back to energy transfer. How much force is applied, over what distance, and how the body absorbs that energy. Let's finish this section by tying together kinetic and potential energy, because those are huge in trauma. Kinetic energy is the energy of motion, anything that's moving. And remember, it's calculated as 1/2 mass times velocity squared. What that means for us in EMS is that speed matters more than weight. Even small objects can cause significant injuries if they're moving fast enough. Now, on the flip side, we have potential energy. That's stored energy, or energy waiting to be released. This is most commonly related to height and gravity, like a fall. The higher something is, the more potential energy it has, and the more energy gets transferred when it falls. So whether it's a high-speed MVC or a fall from a height, what we're really thinking about is how much energy was transferred to the body, because that's what predicts injuries. Now we're moving into mechanism injury profiles, and this is where your clinical thinking really comes in. Different mechanism of injury, or MOIs, can produce a wide range of injuries, even if the patient looks okay on the surface. On the lower end, we have what are considered non-significant injuries. These are typically things like an isolated injury to one body part, maybe a simple extremity injury or a fall where the patient didn't lose consciousness. But even here, don't get too comfortable, because your job isn't just to label something as minor. It's to stay aware of what could be happening underneath. Now, on the other end of the spectrum, we have significant injuries, and these are the ones you should immediately raise your level of concern for. We're talking about injuries that involve more than one body system, also known as multi-system traumas. But it's not just what you see, it's also the mechanism. Things like fall from height, motor vehicle or motorcycle crashes, cars versus pedestrians, all of these involve high energy transfer, which means a much higher risk for serious internal injuries. And then, of course, penetrating trauma, like gunshot wounds or stabbings. These can cause severe damage if the external injury looks small. So anytime you hear one of those mechanisms, your mindset should shift to, what injuries might I not be seeing yet? Because this is where good EMTs separate themselves by anticipating the unseen. Now let's talk about two main categories of trauma that you're gonna see: blunt and penetrating trauma. Blunt trauma happens when a force is applied to the body, but it doesn't break the skin. So think about things like car crashes, falls, or someone being struck. Energy is transferred, but there's no open wound. The tricky part with blunt trauma is that a lot of the damage is internal, so it's not immediately obvious. On the other hand, penetrating trauma occurs when an object actually pierces the body, like a gunshot wound or stabbing. With these, the injury path can be more obvious, but you still have to think about what structures were damaged along that path. And remember, both blunt and penetrating trauma can happen from a variety of mechanisms. So again, it always comes back to asking yourself, what force was involved and what did it do to the body? Let's take a closer look at blunt trauma, because this is what you're going to see often. Blunt trauma results from an object making contact with the body. So again, things like motor vehicle crashes and falls are the most common mechanisms here. Now, even though there may not be any open wounds, you still want to be really alert for signs like skin discoloration, bruising, and pain, because what you see on the outside may only be a small part of what's actually going on the inside. This is where that high index of suspicion becomes critical. So just because the patient looks okay, it doesn't mean that they are. We should always be thinking what kind of force was involved and what injuries could be hiding underneath. Let's get into vehicle crashes. This is one of the most common and high-risk mechanisms that you'll respond to. A crash actually consists of 3 separate collisions. First, you have the vehicle striking another object, like a car, tree, or a pole. And this is where your scene size up becomes huge. By looking at the vehicle, how much damage there is, where the impact occurred, you can start to determine the mechanism of injury and how much energy may have been transferred. The general rule, the more damage you see, the more energy transfer, and the higher risk for serious injury. So don't just look at the patient, look at the car, because the car tells a story before our patient ever does. The second collision in a vehicle crash is the passenger hitting the interior of the car. So even after the car stops, the patient's body keeps moving forward until it hits something like a steering wheel, a dashboard, a windshield, or a door. This is where we start to see specific injury patterns. Common injuries include lower extremity fractures, especially from a dashboard, flailed chest from impact with a steering wheel, or head injuries from hitting the windshield or the pillars. And again, this is where your assessment skills come in. Look inside the vehicle. Damage to the dashboard, a starred windshield, a bent steering wheel, those are all clues telling you what your patient's body hit. So you're not just assessing the patient, you're using the vehicle to also help predict injuries. Now the third collision, and honestly the most dangerous one, is what happens inside the body. This is where the patient's internal organs keep moving and then slam into the body's internal structures. And this is where injuries can become life-threatening, even when there's very little to see on the outside. A classic example of this is a brain injury. The brain continues moving forward and hits the inside of the skull. That's called a coup injury. Then it rebounds and hits the opposite side, which is called a contre-coup injury. So we can actually have injury in multiple areas of the brain from a single impact. The big takeaway here is that internal injuries are often not obvious, but they're often the most serious. So let's wrap up vehicle crashes by talking about a significant mechanism of injury, those red flags that should immediately raise your concern. If there's been a death in the same vehicle, you should automatically assume high energy event with serious potential injuries. Severe deformity of the vehicle or intrusion into the passenger compartment, that's another big one, because that means the space that your patient was sitting in was compromised. You also want to pay attention to severe rear end damage, especially with rapid acceleration or deceleration forces. Crashes that involve rotation or rollover add another layer of complexity, because forces often come from multiple directions. And then ejection from the vehicle. This is one of the highest risk findings. If a patient has been ejected, you should be thinking major traumas until proven otherwise. So when you see any of this, your mindset should immediately shift to a high index of suspicion, rapid assessment, and priority transport. Now let's start breaking down frontal crashes, because these are the ones that are the most common types of vehicle crashes. One of the first things that you want to evaluate is the supplemental restraint system. Ask yourself, was the patient wearing a seatbelt? Did the airbags deploy? Because these factors can make a big difference in how the body moves during a crash. Seatbelts and airbags are designed to prevent that second collision, keeping the patient from slamming into the interior of the vehicle. And airbags, in particular, help reduce the severity of deceleration injuries, especially to the chest, face, and head. Here's the key though, just because restraint systems were used doesn't mean there's no injuries. Now, even with airbags and seatbelts, you still need to anticipate injuries, because restraints don't eliminate injury, they just change how the energy is distributed. So in frontal crashes, you should still be thinking about injuries to the extremities, especially from that second collision, where the body hits the interior of the vehicle. And then, just as important, you need to consider injuries to the internal organs from that third collision. Remember, the body may stop, but the organs keep moving. So even if everything looks controlled on the outside, there still can be significant internal damage. That's why your assessment has to go beyond what you see and focus on what could be happening underneath. A couple important safety considerations with frontal crashes, especially when it comes to special populations and scene awareness. First, children shorter than 4'9" should always be in the rear seat. That's because airbags, while are protective for adults, can actually cause serious injury to smaller children in the front seat. And then, from a provider safety standpoint, if an airbag did not deploy during the crash, you need to assume it still could deploy during extrication. So you always want to be aware of undeployed airbags and avoid positioning yourself directly in their path. Now, this is an important reminder also. Supplemental restraint systems can still cause injury, even when they're used appropriately. Seatbelts, for example, can leave what we call seatbelt sign, bruising across the chest or abdomen, and that should immediately raise concern for underlying internal injuries, especially to the abdomen. If a seatbelt is worn improperly, too high or too low, it can increase the risk of injury to that area even more. But even when it's worn correctly, the forces involved in a crash can still cause damage. So again, don't let the presence of a seatbelt or airbag make you assume that the patient is okay. To wrap up frontal crashes, one of the most important things you can do is a quick evaluation of the vehicle interior. You're specifically looking for contact points, places where the patient's body likely struck something. A steering wheel, a dashboard, windshield, door, or even the roof maybe. These points of contact give you critical clues about how the body moved during the crash and what injuries to expect. So this doesn't need to be a long assessment, just a quick scan as you're moving in, but it can tell you a lot. Now let's talk about rear end crashes, which are most commonly associated with whiplash type injuries. In these collisions, the body is pushed forward suddenly and the head tends to lag behind. Then it snaps forward. In these collisions, the body is pushed forward suddenly, but the head tends to lag behind, then snaps forward. That rapid back and forth motion puts a lot of stress on the neck and the cervical spine. These injuries are especially more severe when there's no headrest or if it's positioned incorrectly. So even if the crash doesn't look dramatic, patients can still have significant soft tissue or C-spine injuries. This is another example of why mechanism matters, because the movement of the body tells you what injuries to expect. Let's break down what's actually happening to the body in a rear end crash. As the vehicle is struck from behind, the body is suddenly propelled forward and the head and neck lag. That creates rapid extension and flexion movements, which we describe as whiplash. And it's not that even just the neck you need to worry about. This type of motion can also cause acceleration type injuries to the brain, even without a direct blow to the head. So patients may present with things like headache, dizziness, or confusion, even if there's no obvious signs of trauma. Again, the mechanism matters, because understanding how the body moved helps you anticipate injuries that you can't immediately see. Now let's move into lateral crashes, or side impacts. And these are some of the most dangerous types of collisions. In a side impact, there's very little space between the point of impact and the patient. So unlike frontal crashes where there's more structure to absorb energy, here that force is transferred directly into the body. That's why lateral crashes are a very common cause of death in MVCs. The body's pushed sideways, and you often get a type of lateral whiplash where the head and shoulders are thrown towards the point of impact. So right away, you should be thinking about injuries to the head, neck, chest, and abdomen on the side that it was struck. Again, that mechanism tells us a story. In lateral crashes, that story usually involves a high risk for serious internal injury. Let's break down what's actually happening in a lateral crash. When a vehicle is struck from the side, it's usually hit above its center of gravity. That causes the vehicle to rock or move away from the point of impact. And as that happens, the patient's body is forced sideways, creating a lateral whiplash motion. So instead of that forward-backward motion that we see in rear-end crashes, this is a side-to-side force. And again, that means the head, neck, and torso are all being pulled in ways that they're not designed to handle. So when you hear side impact, your brain should immediately go to high risk and the potential for serious internal injuries. Wrapping up lateral crashes, let's talk about what happens when there's significant intrusion in the passenger compartment. If the side of the vehicle is pushed in, you should immediately suspect injuries on the same side of the body. That includes chest and abdominal injuries, especially to organs like the lungs, liver, or spleen. You also should be thinking about fractures, particularly the ribs, pelvis, and lower extremities. And just like with other high energy mechanisms, don't forget about that third collision, the internal movement of organs, which can cause serious damage. Let's talk about rollover crashes, which are some of the most unpredictable and dangerous mechanisms that we'll encounter. Certain vehicles like large trucks and SUVs are more prone to rolling over because they're high center of gravity. In these crashes, injuries can vary a lot depending on whether the patient was restrained or unrestrained. And the biggest concern and most important life-threatening findings is ejection or partial ejection from the vehicle. Once a patient is ejected, they're exposed to multiple impacts, which significantly increases risk and severe multi-system trauma. Rotational crashes or spins. These are conceptually similar to rollovers that they involve uncontrolled movement of the vehicle, but instead of flipping, the vehicle's rotating. The danger here is that as the vehicle spins, it can strike multiple objects, like other vehicles, guardrails, or utility poles. So instead of one single impact, you may have multiple points of impact, each transferring energy to the patient. That means injury patterns can be complex and unpredictable. Let's talk about car versus pedestrian incidents, which are some of the most severe mechanisms that we will encounter. These injuries are often very graphic and obvious, but don't let that distract you. There can also be serious internal injuries that you can't see right away. So your assessment really needs to focus on mechanism. You want to determine things like the speed of the vehicle, because higher speed means higher energy transfer. Was the patient thrown through the air? If so, now we're dealing with multiple impacts. What kind of surface did they land on? Concrete versus grass makes a big difference. And were they struck and then pulled under the vehicle? Because that introduces crush injuries and prolonged force. So with pedestrian strikes, you're not just treating what you see, you're building a big picture of everything that happened to the patient. To wrap up the car versus pedestrian incidents, don't forget to also assess the vehicle itself. Damage to the vehicle can give you important clues about where the patient was struck and how much force was involved. And because these are typically high energy mechanisms, you should strongly consider the need for ALS. Any patient with a significant mechanism injury like this should be treated as high risk for multi-system trauma. Let's look at car versus bicycle accidents, which you should approach very similarly to a car versus pedestrian. This is still a high mechanism, and this patient is very exposed. So you want to evaluate the scene the same way, looking at the damage and position of the bicycle, because that helps tell the story of impact. And one really important piece here is the helmet. If the patient was wearing one, you need to inspect it closely for damage, because a damaged helmet should immediately make you think about head and possible spinal injuries, even if the patient looks okay initially. You should always assume a spinal injury until proven otherwise. These patients are at high risk for spinal column and spinal cord injuries, even if they're awake and talking. So your approach should be cautious from the start. That means initiating spinal stabilization early and maintaining it throughout your entire patient encounter. Don't wait for obvious signs, because sometimes those don't show up right away. So again, let the mechanism guide you. High energy impact, unprotected patient, you should be thinking spine until proven otherwise. Now let's move into car versus motorcycle, which are another high risk mechanism. Unlike someone in a car, motorcycle riders have very limited protection. Really, their protection comes down to things like a helmet, abrasion-resistant clothing like leather and boots. And while these can help reduce certain injuries, especially road rash and head injuries, they don't absorb the energy the same way that a vehicle does. So a lot of that force is still being transferred directly to the body, which means even if a rider is fully geared, you should still have a high index of suspicion for serious injury. All right, so when you're assessing a motorcycle crash scene, this is where your scene size-up skills really matter. You want to look at the whole story that the scene is telling you. Look at the motorcycle itself. How damaged is it? Is there major deformity, or does it look relatively intact? Pay attention to the side of the impact, because that often correlates with where your patient is going to be injured. Take a second look at the roadway. Is there a long skid mark that can give you an idea of speed and force involved? Also look beyond just the bike. Check for damage to other vehicles or stationary objects. And one of the biggest clues, look at the helmet. If there's significant deformity, cracking, or impact marks, you should immediately be thinking head and C-spine injury. Now let's break down a couple common types of motorcycle crashes, because this helps you predict injuries. First, head-on crashes. In these, the motorcycle hits something and stops suddenly, but the rider keeps going forward. So think about what that means. Your patient is essentially being thrown into whatever is in front of them, whether that's a vehicle, the ground, or another object. This is where you want to start thinking head, chest, and abdominal trauma, and definitely a high risk for multi-system injuries. Then you have angular crashes. This is when the motorcycle strikes something at an angle instead of straight on. And what happens here is that the rider often gets pinned or crushed, especially in the lower extremities. So these are patients you should be looking closely for things like femur fractures, tib-fib, and pelvis injuries. The last piece for motorcycle crashes is a big one, ejection. When a rider is ejected, they're going to continue traveling at a high speed until something stops them. That could be the ground, another vehicle, or a guardrail. Whatever it is, that's where the energy transfer happens. So these patients often have significant multi-system trauma, and you should be thinking high index of suspicion across the board. Head, chest, spine, abdomen, extremities, everywhere. Now on the flip side, you might hear something called a controlled crash. This is actually a technique that riders may use to separate themselves from their motorcycle to try and reduce injury. But here's the key. Even though it's controlled, it's still a crash. So don't let that wording fool you. These patients can still have serious injuries, especially from impact with the ground or secondary objects. Now let's talk about falls, which might seem simple, but can actually be really serious depending on the height. The biggest thing you're considering is how far the patient fell. Once you get above 20 feet, that's considered significant mechanism of injury, and your concern for serious trauma should go way up. And remember, it's not always what you see on the outside. With falls, internal injuries are often the biggest threat. So even if the patient doesn't look bad initially, you still need to be thinking about things like internal bleeding, head injuries, or spinal trauma. Don't underestimate a fall, especially if there's height involved. Now let's talk about potential lands, because that matters just as much as the height. If a patient falls and lands on their feet, it might seem like a better outcome, and sometimes it is, because the legs absorb a lot of that energy. But here's the catch. That energy doesn't just disappear. It travels up the body. So while you may see injuries to the heels, legs, and ankles, you also need to be thinking about pelvis and spinal injuries. So don't let a feet-first landing give you a false sense of security. You still need to have a high suspicion for spinal trauma, even if the patient is walking or talking. Okay, the last piece on falls, and this is where we start putting things together. When you're assessing a fall, there are a few key factors you always want to think through. How high did they fall from? That's going to give you a big clue about the amount of energy involved. Next, what did they land on? Falling onto grass is very different than falling onto concrete or asphalt, so the surface matters. And then probably the most important piece, what part of the body hit first and where did that energy go after? Because again, energy travels through the body. So if they hit head first, you're thinking head, neck, and spine. If they land on their side, now you're thinking chest, abdomen, and pelvis. Now let's move into penetrating trauma, which is actually the second leading cause of trauma-related death after blunt trauma. This type of injury can happen accidentally, like an impalement, or intentionally, such as a knife, an ice pick, or another weapon. The key difference here is that instead of force being spread out over the body, like in a blunt trauma, this energy is focused in a very small area, allowing an object to actually pierce through tissues and organs. Even something that seems smaller or less dramatic on the outside can still cause significant internal damage because the path that object takes through the body determines what structures are involved. So with penetrating trauma, you always need to be thinking beyond what you can see and considering what might be happening under the surface. Now, when we're talking about low energy penetrating trauma, like stab wounds, these injuries are primarily caused by sharp edges of an object moving through the body. So instead of large transfer of force like we would see in a blunt trauma, this is more about the pathway that the object takes and what it cuts through along the way. There's something really important to keep in mind. What you see on the outside does not always reflect what's going on the inside. In some cases, especially with knife wounds, the object may have been moved or twisted internally, either intentionally or just during the incident. That can cause far more internal damage than you would expect based on the size or the appearance of the external wound. So again, you always want to maintain a high index of suspicion and think beyond what you can physically see. Now we're moving into projectile injuries, things that get even less predictable. The path that a bullet takes through the body is not always straightforward, and that's what makes these injuries so dangerous. A bullet can actually ricochet within the body, bouncing off structures like bone and changing directions before it exits, if it ever exits at all. The path that the bullet travels is called its trajectory, and it can be very difficult to determine by looking at an entry wound. On top of that, if bullet fragments, those smaller pieces, can create multiple injury pathways. increasing the amount of internal damage significantly. So again, with these patients, you can't rely just on what you see externally. You have to assume that there could be extensive internal injuries along an unpredictable path. Here's an important concept with projectile injuries: cavitation. As a bullet moves through the body, it doesn't just damage the tissue it directly touches. It creates rapid pressure changes in the surrounding tissues and fluids, which causes them to stretch outward and then snap back. This creates what we call a temporary cavity, where the tissue is pushed away from the bullet's path, and a permanent cavity, which is the actual track of the destroyed tissue being left behind. The problem is the temporary cavitation can cause significant damage to surrounding organs and structures, even if they weren't in the direct path of the bullet. So again, what you see externally or what you think the path is might not reflect the true extent of the injury. The relationship between distance and severity isn't always straightforward. It really depends on the type of weapon involved. As a projectile travels, it's affected by air resistance or drag, which slows it down over time. But here's the key point: the amount of damage a projectile causes is not just about its size. In fact, the area of damage is usually much larger than the actual diameter of the bullet. That's because the energy being transferred into the body spreads outwards, especially with higher velocity projectiles. And most importantly, the energy that causes damage is much more related to the speed of the projectile than its mass. So higher speed projectiles are going to cause significantly more tissue damage, even if they're smaller. This table is really just putting everything together and helping you recognize developing problems in trauma patients, whether it's blunt, trauma, or penetrating. What I want you to focus on here is not memorizing every single detail, but understanding the patterns. Now we're moving into blast injuries, which are a little different than everything we've talked about so far. These are most commonly seen in military conflict, but they're definitely not limited to just that. You can also see blast injuries in civilian settings like mines, shipyards, chemical plants, and unfortunately terrorist attacks. So while they may feel less common, they're absolutely something you need to be prepared to recognize, because when they do happen, it often involves multiple patients and complex injury patterns. This image is showing you the different mechanisms of blast injuries, and this is where things get more complex. When an explosion happens, it's not just one type of injury. It's actually multiple layers of injury happening at the same time. You've got the primary blast injury, which comes directly from the blast wave itself. Then you have the secondary blast injury, which is caused by flying debris. And then finally, quaternary injuries, which are kind of everything else. So let's break those down a little more clearly. Primary blast injuries. These are caused entirely by the blast itself, that rapid change in pressure moving through the body. This type of injury tends to affect the air-filled organs, like the lungs, ears, and GI tract. Secondary blast injuries happen when the patient is struck by flying debris. So think shrapnel, glass, metal, anything that's propelled by the explosion that can penetrate or injure the body. And then tertiary blast injuries occur when the patient is actually picked up and thrown by the force of the explosion, leading to impact injuries when they hit another surface. So again, we're not just dealing with one injury. You're often dealing with multiple mechanisms at the same time. The last one is quaternary blast injuries, and this is kind of the miscellaneous group, but it's still important. This includes things like burns from hot gases or fires caused by the explosion, respiratory injuries from inhaling toxic gases, or crush injuries if a structure collapses. So these are all additional injuries that don't fall into those first three categories, but can still be really serious and life-threatening. When we're talking about blast injuries, certain parts of the body are more vulnerable than the others. Like I mentioned, those air-filled organs. So something like a ruptured eardrum might be one of the first signs that a patient was exposed to a significant blast. But don't let that be the only thing you focus on, because if the ears are affected, there's a good chance the lungs and other internal organs are injured as well. One of the most serious concerns with blast injuries is pulmonary blast injury, and this typically happens with close range exposure to an explosion. This is where that pressure wave directly affects the lungs, and these patients can deteriorate quickly, even if they don't look bad at first. Another major complication to be aware of is an arterial air embolus. This is when air enters the bloodstream and can travel to the brain, causing symptoms like vision changes, altered mental status, or other neurologic signs. So if you have a patient from a blast who starts showing sudden neurologic changes, this should absolutely be on your radar. All right, wrapping up blast injuries. Not all organs are affected the same way. Solid organs like the liver and spleen are actually a bit more protected from the pressure wave itself compared to those air-filled structures we talked about. But despite that, the most common causes of death in blast injuries are actually neuro and head trauma. But unfortunately, due to the amount of force involved, traumatic amputations are also common, especially in a high energy. Now we're talking about multi-system trauma, and this is exactly what it sounds like. More than one body system is involved. So instead of just a head injury or a broken leg, you're dealing with a combination of head injuries and spine injuries, chest and abdominal trauma, or chest injury with multiple extremity fractures. These are your high acuity patients, and they can deteriorate quickly because multiple systems are compromised at the same time. Because of that, this is where you need to be thinking early notification to medical control and rapid transport to an appropriate facility. Overall, these patients have a high risk of complication and death, so your assessment and decision making here really matter. Now we're getting into the golden principles of pre-hospital trauma, and this is really your foundation for everything we've been talking about. Your first priority always is safety. That means your safety and the safety of your crew, and then the safety of your patient. If the scene isn't safe, nothing else matters. From there, you need to start thinking about whether you need additional resources, more personnel, additional units, or specialized equipment, whatever the situation might call for. And then you're evaluating the mechanism of injury, because that's going to guide everything you do moving forward. Once you've established safety and sized up the scene, your next priority is to identify and manage any immediate life threats. This is where you're thinking about things that will kill your patient right now if you don't address them. After that, you shift into focused patient care, starting with hemorrhage control, making sure you're managing any significant bleeding, then moving into airway and ventilatory support, followed by assessing and treating for shock and considering spinal immobilization where appropriate. Throughout all of this, you need to be thinking about rapid transport, getting the patient to the facility as quickly as possible. And finally, when we talk about trauma care, you have to remember definitive care happens at the hospital, often requiring surgical interventions. That's why your on-scene time should be limited, ideally 10 minutes or less for our critical trauma patients. You do what you need to do, but don't stay on scene longer than necessary. As you're moving, you can gather a sample history and continue with your secondary assessment, but transport should already be in progress. Now we're moving into patient assessment, and this is where you start applying everything we talked about. Your approach is going to depend heavily on the mechanism of injury and how sick your patient is. If the patient experienced a significant mechanism of injury and appears critical, you're going to move quickly into a rapid physical exam. You're looking for life threats and major injuries right away. On the other hand, if the mechanism of injury is non-significant and the patient appears stable, you can slow things down a bit and focus more on their chief complaint. Talking about injuries to the head, and this is an area where things can be deceptively serious. Patients can have significant brain injuries even when they're not obvious external signs. Bleeding or swelling inside the skull can quickly become life-threatening because there's nowhere for that pressure to go. That's why it's so important to include frequent neurologic assessments. You're constantly reassessing things like mental status, pupil response, and GCS. And remember, some patients may look okay initially and then deteriorate over time. So you always want to stay alert for subtle changes. Moving into injuries in the neck and the throat, this is a high-risk area for potentially serious or even deadly injuries because the biggest concern here is the airway. Even a small amount of swelling can quickly lead to airway compromise. And you're assessing, you want to be looking for your DCAP BTLS findings in the neck. Anything abnormal, deformity, swelling, bruising. And remember, swelling in this area doesn't just affect the airway. It can also impact blood flow to the brain, which can become life-threatening. With more severe neck injuries, there's a couple of critical complications you need to be thinking about. A penetrating injury to the neck can potentially lead to an air embolus, where air enters the bloodstream, and that can quickly become life-threatening. And with crushing injuries, There's a risk of fractures to the cartilage of the upper airway and the larynx, which can severely impact the patient's ability to breathe. So again, even if things don't look dramatic on the outside, injuries in this area can progress quickly. And you always want to be thinking ahead to airway management and rapid transport. Now we're moving into injuries in the chest, another area where you can see immediate life threats. The chest houses some of the most critical structures in the body, the heart, lungs, and major blood vessels. So any trauma here should raise your concern right away. There's several serious injuries you need to be thinking about. Broken ribs can make it difficult for patients to breathe effectively, which can quickly lead to respiratory compromise. And the heart itself can be bruised, which affects how well it pumps. And in more severe cases, large blood vessels can be torn, which can result in massive internal bleeding. Let's talk about a very specific chest injury, an open chest wound. This happens when there's a penetration or hole in the chest wall, which can disrupt normal breathing. If this goes untreated, it can quickly lead to shock or death. So this is something you need to be able to recognize and act on fast. Ongoing assessment is key here. You should be reassessing the chest at least every 5 minutes, especially if the patient is unstable. And your assessment needs to be thorough. Looking for that decap BTLS. Listen to lung sounds. Watch for equal chest rise and fall. Moving into abdominal injuries, this is one of the areas where things can go bad really quickly without any obvious signs. The abdomen houses multiple vital organs, and many of them require a significant amount of blood flow. So when an injury occurs, there's risk for serious internal bleeding. Now, we divide those organs into categories. You have the solid organs like the liver, spleen, kidneys, and pancreas. Then these are especially important because when they're injured, they bleed a lot. Then you have your hollow organs like the stomach, intestines, and bladder. Injuries here can leak the contents, which can cause infection and other complications. Now, building on that, let's talk about what actually happens when those injuries happen to those organs. With solid organs, they can tear, lacerate, or even fracture. And remember, these organs are really vascular, so that often leads to significant internal bleeding. With hollow organs, the concern is a little different. These can rupture, allowing the toxic digestive contents to leak into the abdominal cavity, which can lead to serious infection and inflammation. And then you have to think about the major blood vessels in the abdomen. If those are damaged, it can cause massive unseen bleeding, and your patient can crash really quickly. Now shifting into management, especially transport and destination. This is where your decision making really matters. When it comes to trauma, time is everything. The survival of critically injured patients is directly tied to how quickly they get to definitive care. That's why we're emphasizing on-scene times under 10 minutes if possible. This is a load and go mindset. Now, how do you know if your patient's critical? There's a few big red flags. A dangerous mechanism of injury, decrease or decreasing level of consciousness, or any threats to the airway, breathing, or circulation. If you see those things, this isn't a time to stay on scene. You need to package, manage immediate life threats, and transport. Now let's talk about destination selection, because where you take the patient matters just as much as how fast you get them there. Ideally, critically injured trauma patients should go to a trauma center, and there's different levels to understand. A level 1 is the highest level of trauma care. These are typically found in large cities, often university-based hospitals. They can provide comprehensive care for every aspect of trauma, from emergency surgery to rehab. Level 2 facilities are still very capable, but you'll usually find these in less populated areas. They can provide initial definitive care, meaning they can manage serious trauma, but may transfer out more complex cases. So your job in the field is to recognize how serious your patient is and make the best decision for getting them to the right place the first time. Continuing with destination selection, a level 3 facility can provide assessment, resuscitation, emergency care, and stabilization. These facilities are equipped to handle the patient initially, but if the injuries are more severe, they'll transfer them to a level 1 or level 2. Then you have your level 4 facilities, which are typically found in remote or rural areas. These facilities can provide advanced trauma life support, but their main role is to stabilize the patient and arrange rapid transfer to a higher level trauma center. So again, think about the big picture. Your goal is to get the patient to the right care as quickly as possible, even if that means starting at a lower level facility and then moving them up. Now let's talk about when you should be thinking about air medical transport. Organizations like AAMS or Medevac Foundation International have outlined criteria to help with these decisions. Air medical becomes especially useful when time or access is a major issue. For example, if there's an extended period to reach the patient or extricate them, maybe they're trapped or in a remote location, air transport can significantly reduce these delays. It's also important when a patient needs ALS care, but there's no ALS ground units available. You should also consider it in situations with multiple trauma patients or during a mass casualty incident where resources are stretched and rapid transport is critical. The big takeaway here is to think about how quickly you can get the right level of care to the patient or the patient to that care. Air medical is just another tool to help you do that. Now, another important piece of destination decision is understanding that not all trauma centers are the same for every patient. Trauma centers are categorized as either adult or pediatric. Pediatric patients have different anatomy, physiology, and care needs. So whenever possible, they should be taken to a pediatric trauma center. So the key takeaway here is don't take a pediatric trauma center to an adult trauma center if there's an option to take them to a pediatric center. This is about getting the patient to the most appropriate resource. Let's talk about different types of air transport because not every patient and every situation requires the same level of resources. Your ground EMS units are typically staffed by EMTs and paramedics, and this is the most common mode of transport. But in more critical situations, you may need a higher level of care during transport. That's where air EMS or critical care units come into play. These are staffed by critical care nurses and paramedics, allowing more advanced interventions during transport. So again, think about your patient's condition and ask yourself, what level of care do they need while we're moving them? All right, this slide shows you a field triage destination scheme. And while it may look a little overwhelming, it's really just a step-by-step guide to help you decide where your patient should go. We have one of these specific for our region and in our protocols that you should take a look at. But the key takeaway here is that you're not guessing. You're using a structured approach to guide your decision making. And when in doubt, transport them to a trauma center. And finally, let's wrap up this section with some special population considerations. These are things that apply to every trauma call. First, stay calm. Trauma scenes can get chaotic quickly, but your ability to stay focused makes a big difference. Next, make sure you're doing a thorough and organized assessment. Don't skip steps, even when things feel urgent. You also want to identify and correct life-threatening injuries right away. That's always your priority. At the same time, though, remember the principle is do no harm. Be intentional with your interventions and avoid causing additional injury. And lastly, never hesitate to call for help. Whether that's ALS or medical control, use your resources. You're not in this alone. Let's bring this chapter together. Trauma care is all about recognizing that serious injury doesn't always look dramatic at first. Whether it's blast injuries, chest trauma, abdominal bleeding, or head and neck injuries, you have to stay alert for what's happening inside the body, not just what you can see. We talked about how trauma often involves multiple systems, and that's why your approach needs to be organized, consistent, and focused on priorities. Always start with scene safety, then move quickly into identifying and managing life threats, your ABCs. You also saw how important mechanism of injury is. It helps you anticipate what injuries might be present, even before your patient shows obvious signs. And when it comes to management, remember, time matters. Keep your on-scene time short. Make smart decisions about transport and destination, and get your patients to the right facility as quickly as possible. At the end of the day, your role in trauma care is to recognize, stabilize, and transport. You're the link between the scene and definitive care, and what you do in those first few minutes can make all the difference. So stay calm, systematic, and trust your training, because in trauma, every second counts.